Okay. For the next few hours, we're going to be exploring the business case for professional associations, and we've been lucky that in this session, we're going to have, instead of one example, two examples. And one of them is, as I said before in the big group, one of them is more local in the United States example, and the other one will be of an international nature. Okay. I'm going to start. This is what we have for today. We're going to have, first of all, brief introductions, and we'd like to know, since we're going to be here for 2 hours and then tomorrow again, to have go around the tables. And briefly, we have like 2 minutes. No, we have like 15 minutes to go around the table and know who you are and why you're here, and maybe a little bit of your expectations about here. I'll start myself. My name is Silvia Rabionet. I am affiliated to the University of Puerto Rico, where I teach public health and health promotion. I'm also affiliated to Nova Southeastern University College of Pharmacy, where again there I also teach health promotion and health education within the pharmacy curriculum. And I've been working in many different projects related to competency and workforce development locally and internationally, and I guess I'm here because of that, and enjoying this CPD conversation. And well, we have Mike.
Thank you. Good afternoon. My name is Mike Rouse. I'm with the Accreditation Council for Pharmacy Education in Chicago, but I think you will tell from my accent that I'm not originally from Chicago. Originally from Zimbabwe, I've lived in the United States and worked with ACPE for the last 16 years. And a lot of my work in that area has been in advocating, exploring and advocating a new model for continuing education. We are accreditors of providers of continuing education, so it's a major area of our work. And we've recognized, as has been said this morning, the need for a new model. And we've learned a lot from other countries that have introduced a CPD model for pharmacy. And I now do a lot of work internationally also to advocate CPD models. And I'll be presenting a case study of some work that I've been doing in Turkey. In fact, I'm going to Turkey tonight to continue with the work, so I apologize, I will not be here tomorrow. Very exciting project, and look forward to sharing that with you.
Hello, my name is Laura Magaña Valladares. I am the academic dean at the National Institute of Public Health in Mexico, in Cuernavaca, Mexico, but I'm here representing the Association of Schools and Programs of Public Health.
Hi, my name is Nadim Karambaks. I'm the Associate Dean of Academic Affairs at Tufts University School of Dental Medicine, and I'm stepping in at this meeting for Rick Valakovic, who's the President of the American Dental Education Association.
Yeah, I think it's close enough. Hello, I'm Anita James, and in the membership that it shows with the Athletic Training Strategic Alliance, and specifically I'm with the National Athletic Trainers Association, and we're an approved provider for athletic trainers, so I work on continuing education.
I'm Rick Talbot. I'm the Dean Emeritus of the College of Allied Health Professions at University of South Alabama, but I'm here representing the Association of Schools of Allied Health Professions, which is the national group of many of the deans of colleges of allied health professions.
I'm going to try to stretch over there. Hi, I'm Kathy Gross. 2 minutes. I'm Kathy Gruss with the American Psychological Association. So our association does set standards for continuing education for psychologists, and we're also increasingly looking at models for delivering interprofessional CE and how that fits with our association mission.
Oh, okay. Good afternoon, everyone. I'm Karen Lacey, and I'm Emeriti Director of 2 dietetic programs at the University of Wisconsin, Green Bay. And I'm here representing the Commission on Dietetic Registration. that issues the credentialing for entry-level dietitians as well as oversees all of the continuing education for maintaining the credentials. So I appreciate the opportunity to be here as a guest today, and thank you.
And hi, I'm Katie Elliott. I am the undergraduate program director at St. Louis University in nutrition and dietetics, representing the Academy of Nutrition and Dietetics. And while I'm not directly involved in CPD, I work with the learners who will be the future learners in that in the CPD program. So that's my perspective.
Hi, I'm Jody Frost. I'm here with the National Academies of Practice as president-elect, and formerly 25 years with the American Physical Therapy Association, so I have a lot of association background, but we're actually here to really learn about high-value CPD, interprofessional CEUs for the organization of National Academies of Practice that represents 14 health professions.
Hello, I'm Loretta Nunez. I'm Director of Academic Affairs and Research Education with the American Speech Language Hearing Association, representing audiologists, speech-language pathologists, and speech and hearing scientists. Our association is in the third year of a 10-year strategic objective to advance interprofessional education and collaborative practice, and we are concentrating our efforts across the full continuum of pre-licensure education through professional development. So this meeting and topic has certainly significance for our work.
Good afternoon. Stephen Chesborough, American Physical Therapy Association. Within APTA's education scope includes residency and fellowship education that Mark spoke about earlier from MUSC, but also post-professional credentialing and certification. So this topic is perfect for what our unit looks at within the physical therapist community.
I'm Dawn Mancuso. I'm the Executive Director for the Association of Schools and Colleges of Optometry. And while we're not the professional society for optometrists, we are an education organization. So all of our members offer continuing professional development opportunities, and it's a big area of what we get involved with.
Hi, Kathy McGuinn from the American Association of the Colleges of Nursing. I think this is going to be a very interesting topic. I think, with the pushback and the relationship between, vaccines and the thought that it could cause some problems for children, I don't know if you're going to factor that in, but it's an interesting topic.
Good afternoon. My name is Peter Angood. I'm the president and CEO for an organization called the American Association for Physician Leadership. We focus entirely on continuous professional development, primarily around, as the name implies, leadership education, management training, not only for the physicians, but for all of the different types of organizations that we work in. I've got numerous courses, certificates, master's degrees. We have a certificate that's well recognized, a certified physician executive. And I'm also here as a steering committee chair for a relatively new initiative, the National Coalition for Improving Clinical Learning Environments, which is multi-professional. And between that and our own organization's collaborative approaches, these topic areas are very much in our interest.
Hello, everyone. My name is Dorothy Novelis. I am the CPD manager for AACP, the American Association of Colleges of Pharmacy. I manage the CPD initiative for the association.
Yeah, okay. I'm Elena Rios. I'm president and CEO of the National Hispanic Medical Association here. And we're very much involved with training in terms of leadership development, but also mentoring among physicians, young physicians, residents, medical students that are Latino in the United States, and also with our Hispanic Health Professional Associations. We have a network of national Hispanic professionals.
Thank you all. Thank you. Everyone
Good afternoon. I'm Donna Meyer. I'm the Chief Executive Officer for the Organization for Associate Degree Nursing in the United States, which represents the community college registered nursing programs and mainly the faculty. So we have 1,250 community college nursing programs in the country, and all of those faculty have to have continuing education. So we're very much involved in that, as well as leadership development for the faculty and the deans and directors at those programs.
I guess we know a little bit more of each other now. I want to continue because of the interest of time, because we're going to try to present both our cases in 10 minutes and open it to discussion, right? The idea, these are just examples that we put together with the idea that you will have enough food for thought and discuss it further. Well, the case that I'm going to be presenting today is about the training the pharmacy workforce to actually involve in immunizations. And this is the training based on the American Pharmacists Association initiative to train the workforce of pharmacy immunizers. The association uses a need-based education model to identify the areas in which they should intervene, and it's based on a model also put forward by the International Pharmaceutical Federation. And it's based, and we've heard a lot of that today, about what are the needs, how do we translate those needs to services, what competencies are needed to actually do those services, and then how do we engage in education to actually give those competencies, and again, going in circles into the needs. And as we heard this morning, this might be not necessarily a linear process. Any of these processes can feed themselves as they occur. In the case of the pharmacies administering immunization, there was a need, or I identified need, for higher rates of immunizations to achieve national targets, and there was a need for easier access of immunization services by patients. One of the ways to solve that issue, there may be many other ways put forward, was the pharmacy-based immunization delivery. It was involving community pharmacies in the process of delivering those immunizations. That meant that there was competencies needed to be engage the pharmacists to do that, and then give them the certification or the right training so that they could do this and assure the quality of that training. Pharmacists have made a significant stride over the past 20 years, increasing access to immunization and protecting individuals from vaccine-preventable diseases. And I say the word strides because it did not come that easy. Even if the training, and we'll see that the training started back, the specific training or CPD that I will talk today about, it started in 1996 when not many states at that point allow pharmacies to immunize. So the training came before the actual legislation and the authority to do that. So the scope of authority of the pharmacy has expanded during this period substantially. Now the 50 states and the 2 territories allow pharmacies to immunize. Patients' positive perception and acceptance of pharmacists as immunizers have grown, but it was not so a few years ago. At some point, only 10% of the immunizations took place in the maybe less than 10% of the immunization took place in community pharmacies. Now 1 out of 4 immunizations take place in the pharmacy. So it's a growing acceptance. I want to also clarify that I'm going to be talking, because someone talked about the pediatric immunization. The example I'm going to be giving is specifically about flu vaccine in adult population. Not in all states this scope of practice of the pharmacist is not equally in all the states. There are still some vaccines that cannot be provided by pharmacists, and some age groups that are not allowed pharmacists to be the immunizers. Talking about the training itself, the training I'm going to be talking about is the Pharmacy-Based Immunization Delivery Certificate Training Program. This training program is mainly or it's devised by the Association of the American Pharmacists Association certificate program. However, it's not only given by the American Pharmacy Association. The American Pharmacy Association partners with schools, colleges of pharmacy, state pharmacy association, and other corporations, and a group of dedicated faculty and staff all over the United States give the certificate. However, it's a standardized certificate, and the CDC has highly valued this certificate. It is also has the approval of the American ACPE, right? American, it's the American the Association of College of. This is the scope of the training to become an immunizer. It's an innovative and interactive training program that teaches pharmacists the skills necessary to become the primary source of vaccine information and administration. So it's not only about administering vaccine, it's also becoming an educator as well. The program teaches the basics of immunology and has practice, implementation, and legal and regulatory issues. It has three main components. Part of it is taken, modules are taken online and self-studying modules that are done before they come into a live seminar. And then there's also a hands-on assessment injection technique. In order to be an immunizer in many states, there's an additional training requirement, including a CPR course, and in some places they need to adhere to other state protocols and regulation. And there's also, in order to continue being able to be immunizer, there be yearly continuing education that varies by state. Okay. Thinking about putting then value and cost, how do we know that the training is part of the savings or the cost benefit equation? Training the pharmacist workforce is one of those necessary conditions in order to change the scope of practice. Even if we had the legal authority in all the states, and even with the acceptance, still the training, the pharmacy workforce is one of those necessary conditions. More than 280,000 pharmacists are completing this training. And this is the part that I'm going to be talking about in terms of cost. Here again, I'm showing you the part so that you can see graphically how the training started earlier than the full authority was given to pharmacists to immunize. Then let's explore the value proposition. In the period from 2007 to 2013, and this is something that why this period is because that's where I could find the data to build the business case for this. And as Elena was telling me earlier, you have to sometimes do the business case with the data that you have, and this was the reliable data that I could find. There were, in this period, from 2007 to 2013, 235,000 pharmacists were trained. The cost of this training to become immunizer, including the courses, opportunity course, and other requirements, I calculated that it is nearly $2,000 per pharmacist. The total amount invested in training then has been almost $500 million in training to become pharmacists to become immunizers. The more details I passed around a handout that has more details of how I got to this calculations. In this period, in the same periods from 2007 and 2013, there was 75 million flu vaccines were dispensed in community pharmacies. The net cost of each vaccine dispensed in the pharmacy, instead of dispensing it elsewhere, was $32 for each vaccine dispensed in the pharmacy. Then the total net cost saving for this period was $2.4 billion. If we compare it to being dispensed elsewhere. The net cost saving of the period, as I said, was $2.4 billion, but if we subtract to that the cost of the training, we still have a net benefit of $1.94 billion. And my conclusion to this is and for us to open to discussion, was it worth for the American Pharmacists Association invest in this kind of training? Who gained and who benefited? And this is my food for thought. Thank you. I think we'll go to you and then we'll open to discussion. I think I was in my 10 minutes, right?
Do we have a advance? Is that green button? Okay, thank you. Well, Silvia, you've set me an ambitious task to make sure that I do the same and do this in 10 minutes. I believe you do have handouts of my presentation. I hope you do. Do you have handouts? It's in the book? Yes, no? Okay. If you would like a copy, I'll be happy to get you a copy, because I'm going to go through this quite quickly. So I was hoping that there were going to be handouts which you could follow if I was going to miss some of the information. But I'll certainly. They're in the book. Okay. Okay. Great. Thank you. So my example, as I explained earlier, is CPD-based model that we've introduced in Turkey, and it's introduced through the Turkish Pharmacists Association, so the professional body representing the profession in Turkey. I'm going to present my presentation in an overview using a structure that is incorporated into some of the International Pharmaceutical Federation FIP model for quality assurance of pharmacy education. That's what we call the pillars and foundations of educational quality. I think all of you will know of structure, process, outcomes in our framework, which I had opportunity to author. We have added two columns in terms of addressing quality, and those are the columns of context and impact. I think those are probably fairly self-explanatory, but we like to think of those as addressing the social accountability elements of education. Context obviously is also the why that was explained in the business model. We also have three foundations, which is a competency-based foundation for educational quality, being science, practice, and ethics. But I'm going to cover my presentation using the five pillars, and we've provided a reference for some further look at those publications if you would like to. This is in terms of context, what is the CPD cycle that we're using in pharmacy in the United States? This has been adopted by the Accreditation Council as the model and is now being used by many associations within the United States as a way forward for continuing professional development. If you look at the right-hand side of the circle, it's very similar to CPD models that you might see in pharmacy in some of the other countries that were a little bit ahead of the United States in introducing a CPD model. Great Britain, Canada, New Zealand, etc. We felt, however, that just the right-hand side, which is really the learning side of the CPD model, was not really presenting the full story of CPD or the full value of CPD. And we saw the key difference really as being the application of the knowledge, as in IOM terms, bridging the classroom and the workplace. So this is really why we decided to change our model, and it looks a little bit different to the pharmacy CPD cycle in other countries. Some of the work that I'm doing internationally, for example, in Turkey, several other countries now have adopted this depiction of CPD. So as we've already discussed this morning, it's quite different to traditional approaches to continuing education. If we think of continuing education more in the terms of structured learning activities, that would just be the learn part of the CPD. So CPD, much more holistic approach to learning. We also talk about CPD as a way to learn and a reason to learn. And this is actually pre-publication. We're hoping to get a publication out about some of our later thinking in terms of developments with CPD. But we talk about major concepts being different between our old ways of thinking. One is stressing the commitment to change, and I think this is vital. And second is the motivation for learning. And the example that I'm going to present in Turkey has demonstrated very clearly that seeing the impact of learning is an extremely strong motivator for further learning. So again, learn today, apply tomorrow. We think this is essential in terms of motivating pharmacists to learn and other healthcare professionals. One of the problems with our CE traditional approaches is that this connection between learning and application has not always been strong enough. So very systematic process, a holistic approach to lifelong learning, strong alignment of learning with practice, organization, and patient societal needs, and as I mentioned already, commitment to change and motivation for additional learning. So what is the why or the context? 34,000 pharmacists in Turkey. They're all members of the Turkish Pharmacist Association. About 25,000 in community pharmacy practice, single owner pharmacies, no chains. The Turkish Pharmacist Association is politically influential and well-resourced. It is divided into 54 regional chambers. As I've mentioned, no CE requirements. It's licensure for life. There was no national vision or plan for pharmacy education. And importantly, a very traditional retail. I'm using the word retail as opposed to community pharmacy, a very retail model, limited scope of practice for pharmacists with respect to clinical services. And pharmacists in Turkey were very anxious about the future viability of the practice model, the business model. There was a lot of pressure from the government in terms of price of medication, which of course was the main source of income for community pharmacists. And the pressures were there, and the pharmacists were very anxious about their future business viability. Low motivation and self-image. Previous national initiatives had not really achieved the desired impact. Asthma and COPD, a big health problem. It was found at baseline that 80 to 90% of patients, for example, were not using inhaler correctly. So the project was introduced. It's called the SMART project, SMART being, as you know, specific, measurable, achievable, relevant, timed. That's where the wording came from. 2 international advisors we used. That's myself and a colleague from Croatia who has her own educational company. We introduced a national competency framework for pharmacists based on the FIP model. We introduced a self-assessment instrument so pharmacists could self-assess their competencies to look at future learning opportunities. We introduced quality indicators for services in the pharmacy, again, so that they could self-assess against that instrument and identify opportunities for improvement. We introduced a learning portfolio for the pharmacist and the new smart education model, as I've mentioned, based on pillars and foundations of quality. It was started in 2014, which was really a stakeholders meeting of all stakeholders in Turkey came together to discuss it. It was initially conceived as a CPD, introducing CPD, but then it went much further based on needs and priorities that were identified by the stakeholders. And then in April 2015, we initiated a pilot in 8 of the 54 regional chambers. The details of what was built into that, it was a very comprehensive pilot that was introduced through a 3-day Train the Trainer program. May to October, the pharmacists in those chambers had implemented the project. They were trained at a local level, and then they went back into the pharmacies and implemented the ideas with asthma patients. They collected a lot of patient data. Fairly limited in the pilot phase. We just deliberately kept it quite small, but we involved 386 patient visits, as you can see there. There was also a 1-day training program to provide a refresher in terms of asthma, review of pharmacotherapy, how to instruct patients on correct inhaler technique, patient education, asthma control test, how to measure peak flow rates of patients with asthma, recording the frequency of inhaler use, and other lifestyle changes and quality of life indicators. Beyond that, after the successful implementation of the project, it was rolled out on a national basis based on our findings and conclusions. We made some small changes to some of our training programs. Some of our tools and resources were changed. We developed an online platform to make the whole process, particularly of patient data collection, a lot easier. The discussions of the project were expanded to the national level. There was a lot of social media activity. The results were presented to the Minister of Health. He was very, very impressed by that, and he advocated for further work in the area to actually certify pharmacists as healthcare advisors and actually pay them to do it, which of course is music in the ears of people who are working hard to get recognition for their services. So as I've mentioned, we've already rolled this out through national program, and essentially all of the chambers have now been involved. 3,535 pharmacists have been trained. If any of you follow Roger's innovation, you'll know that this is about 14%, which corresponds approximately with your early adopters. Very important was patient education. Just some statistics, we saw salbutamol use reduced by 30%, improvement on asthma control tests, 76%, and peak flow rate improvement of 40% on average. Of course, results for patients, for pharmacists in terms of their self-assessed competence went up, as well as quality of services. In terms of the impact, new professional services introduced in the pharmacies, patients' quality of life improved, some incorrect diagnoses were identified, a lot of changes in patient lifestyle and habits, enhanced competence and confidence of pharmacists, Minister of Health I've mentioned, and of course enhanced reputation for the association. It has a stronger role with its members, providing expanded member services and benefits. Those are the comments I would like to make. It's a little bit of a rush. As we go on to the next part of our discussion, we're going to explore a little bit more about the value proposition. What I will just mention in closing is that we have not yet done an economic impact of the introduction of the program, but that is proposed, not only in terms of the specific measures that we gave, how much by reducing salbutamol usage, how much does that benefit, the nation, et cetera, et cetera. We have not yet done that, but those will all be done. So with those comments, I'll wrap up, and I think we're going to transition into the next part of the discussion. Escape out of there. I'm not going to show that.
What is the approximate percentage of pharmacists that are giving immunizations versus the workforce? Do you know offhand?
Fine, exactly. That number varies depending on the microphone. I tried to find that number, and it varies by state. But and in the published data that there is, I think that not more than, I couldn't find anything higher than 40% of the pharmacists in any particular area being able to immunize. So there is a lot of room for more training to pharmacists. I don't know if any of the other people are from the pharmacy field would know more about that number, but in the published data, I couldn't find any particular one that went beyond the 40%.
And just if you look at your figures that you've presented, you said 285,000 pharmacists have been trained. I'm not sure how many of those pharmacists are active, but I think current estimates are about 350,000 pharmacists. So it's a fairly high percentage that have gone through training at some stage.
But that, in terms of that translating, again, as you say, that they are actually in places that they can do the work, because remember, it's not only about being trained, it's being trained plus having the authorization of the state to do it, plus having a venue to do it, so that they are involved in programs in community pharmacies or in other programs in which that there's a program for them to be able to be in.
And as a follow-up, is there a financial incentive for them?
So far, that's one of the, again, this is from the challenges in putting this. Not necessarily, they cannot charge extra for this. There is a financial incentive for the pharmacist, for the pharmacy, but not necessarily there's a financial incentive for them. They're not being paid more to do this. This is part of the work they do. However, there are some articles that I read that they like that the pharmacists there's been increasing acceptance among the pharmacists because it increases their clinical roles, and it's another scope of work.
I also know that some employers are now requiring it of their pharmacists. They're requiring that they have that training. So it's a sort of condition of employment now. And that's obviously not pervasive, but certainly I think some of the bigger chains, for example, are requiring their staff to go through that training.
So I have a couple of questions. I actually live in a rural area where administration of some of the vaccines, like the shingles vaccine, is now redirected to the pharmacists from our physicians. They're actually sending them to that service. And it's a rural area. But there's a question I have. What kind of repercussions are there for the pharmacist who delivers the vaccine inappropriately or wrong? And I'm a recipient of that. The shingles vaccine. It was supposed to be IM, and he actually hit a vein, and my entire arm went black and blue. And I went back to show him that when he was delivering it, it wasn't being administered right because I told him it's not right, and he said it's fine. So what are the repercussions or implications for the certification of a new group of healthcare workers with the vaccines when done wrong?
I think that varies state by state. In some states, they are able to practice on their own, and the repercussions will go to the place where they are. The liability. Let me say the liability will be based there. In some states, they work under protocols of doctors, a physician, so it will be a shared responsibility in terms of liability. Again, I'm talking about what is published. The incidence of adverse effects or things done wrong in the pharmacy versus in the doctor's office, there seems not to be much difference. I don't know if it's, that's one of the, if we were going to talk about the stakeholders and the controversies about this, they go beyond having issues like bad vaccination event, but it goes beyond that. It say that they are taking away the ability to do other preventive services that you do when you visit the physician's office, right? Because you're only going to get the vaccination and you're not taking the time to go and get other services. Again, the literature there, the published data is not there yet to say go one way or the other. Is there conflicting evidence about that? There's also saying that not necessarily the access has improved, but not necessarily the rate of vaccination, especially with the flu vaccine. The same amount of people are getting their vaccination. It's not that this is increasing the rate of vaccination. Again, there are some pockets of population in which maybe the rate increased, but generally at the population level, there's no evidence of a change in the rate of.
So just to follow up, I think the concern on all the high-value CPD, if we're introducing new skill sets to individuals prior to after licensure, I think this is a risk that we need to talk about in any of the professions where they're expanding scope. How do we deal with the possibilities, and not a prevalence, but the possibilities of those people who have not really demonstrated competence, and we're allowing that to continue without some kind of remediation or something effectively that really on-site attests to the competence. And this is an example, but it's across all the professions as we continue to do this.
And in some states, I have to say that when I look state by state, and in some states, you only take the course once, and that's it. You don't even have to pay an application or be registered or anything. In other states, you have to be registered and there's continuing education attached to it. So that's something that we should consider, especially when you have changing roles and change of scope of practice.
I know you're university-based and you're accreditation-based. Could you just comment on the role for the professional association that you're referring, in this case, pharmacists?
In this case specifically,
the association.
The association partners with, to give this example that I gave just now, the association gives some of them directly, but the association also partners with universities to give the same course. So the role of the profession. Again, and also this has been successful enough in terms of interest and changing the scope of the pharmacist that now it's being required for students to get some training like this for accreditation purposes. Students have to take it while they are doing their where they're getting their degree. Okay, so that's Elena.
Just following up on the question, who developed this course? Who paid for the development of the course? Because that's a major cost that has to be taken into account in the business case. And the second part is, did the pharmacist actually pay for the training, or did their pharmacies pay for that, their employers pay for that?
I think you probably get both. In terms of the development of the course, I think the association invests in developing it and revamping it and making sure that it is if you go to the website of every state and every provider of this, they have to authorize the providers of this training, and it looks very similar. So it's a standard. And then again, how do they actually make sure that it is delivered at that standard? They have trainers that are authorized by them, by trainers. I didn't put that into the cost. The cost of the trainers, I didn't, when I calculated that. But I thought, and this is a question from me, I thought that when you put charge to the training, you're already taking into consideration that, because it's $350 that the association charges for that. Will that development activity be included in that fee? No. So that, well,
That's the cost to the employee, that's the revenue. Right?
The revenue.
So that's the revenue. So that's the revenue. The cost would really be the cost of development. So they may be offsetting some of their development costs through the revenue that they're getting, but they need to be accounted for separately.
Okay. I didn't have that information when I put the case together.
Oh, there it is. I just had a question about patient education and whether that's included in the curricula for the pharmacist, because as you know, there's a debate going on in this country related to the safety of vaccines. And the mercury component, thimerosal, preservative or whatever, I probably did not pronounce that correctly. But anyway, I think, what do pharmacists know about that when they have anxious patients that come in and are concerned about that? Are they able to have the patient education with them? And then, are the vaccines now being produced without the mercury-based preservative? That's what I'm interested in.
I'll answer as best I can. Certainly, what you were referring to is the thimerosal. Thimerosal is the ingredient that you were referring to. But pharmacists, that would be definitely included in the education of the pharmacist, is the risks, what's the composition of the vaccine, how is it stabilized, all of those elements are all built into the training for the pharmacist, and they would be, again, educated on how to educate the patient in those areas. Pharmacists, again, would be aware of the controversies associated with the administration of immunization. So this should be all part of the training program so that they can appropriately counsel, because, sometimes a patient may come in and ask for advice and leave not happy with not satisfied with the answer. So this should all be built into the training for the pharmacist, so that they can appropriately answer the questions and the concerns of the patients. I know I'm not completely up to date in terms of the manufacture of vaccines, but I know that the thimerosal they're looking at other ways to stabilize, the preparations and reduce the dependence on those kind of agents, which, are controversial and have had problems associated with them.
Before we go to that question, I also want to let you know there are some published information about the role of the pharmacist as educating about the vaccine, not as the role as immunizers. I just gave the example here basing it on the role of immunizing, but there are some information also about pharmacists having that role only of the education role. And because that came before they were allowed to be immunizers. Okay, they've been doing that even before they had the authority to immunize.
Yeah, I was going to say, on the multivalence of the vaccines, the patients would be coming in and asking about which they're getting and things. But my question was, since 50 states now have some form of approval from a legal standpoint of this going on, have the accreditation rules changed in order to, so that they don't have to go through a continuing professional development program, but rather that it be a part of the scope of practice in the PharmD programs? And what's the status of that?
Well, I think that they're trying to get there because they have included it in the curriculum now, but I think that still we're not there. The law might be there, but I don't think the complete scope of practice, only 24% of the or we could say now 24 or 25% of the vaccines, I'm talking about flu vaccines, are now in the pharmacy, but there's still not there's still 75% of the people who don't get vaccinated through the pharmacies.
Yeah. Certainly from an accreditation point of view, because we ACPE accredits both the degree program education as well as the continuing education providers. So immunization being such an important topic, we, as an accrediting body, we ensure that that's addressed in the in the pre-service education of pharmacists. I think maybe AACP might, the American Association of Colleges of Pharmacy may know, but I think virtually all pharmacy, or certainly the majority of pharmacy schools, are now putting their students through the immunization program. So it's definitely a part of the curriculum. It'll be taught in the curriculum, but in addition to it being included in the curriculum, as we would expect as accreditors, I think the mechanism of instruction is actually, in most cases now, using the accredited continuing education program, the certification program. This is now how I believe most pharmacy students are getting that skill. It's certainly covered on the theoretical side in the curriculum as well.
I think, I mean, this case is so interesting from a lot of different perspectives. Certainly scope of practice is one, and you can think of many examples, use of Botox, et cetera. The other things it brings up, and this is an example in dentistry, is the professional organizations and how they try to hold on to their bits of practice. Certainly with teeth whitening, for example, there was a case in North Carolina where a lot of commercial operations in malls were doing this. Dentists were concerned that, they're not looking at the lesions in the mouth, et cetera, and the ruling was against the professional organizations as being self-serving. So certainly I think that's part of any discussion around scope of practice. The other piece is that, certainly when you think about the number of CVS, Walgreens type operations that are in the community, there's a big advantage to letting people just have access to immunizations without traveling into hospitals. And then the other question I have is whether there's any thought about, and this was certainly a topic, I think, around bioterrorism, in terms of preparedness for using those sites and those providers in the case of an epidemic breakout or a bioterror event to deliver, vaccinations or antibiotics or whatever it is. So I don't know if that's something that also, in terms of thinking about a business plan or business model as an advantage, is part of the discussion.
Again, that has been discussed, and especially in any plan for preparedness plan, pharmacists and the stockpile through the pharmacies is something discussed, but it's definitely there, and changing the scope of practices. I think that when you see that looking about the things historically and culturally, as you say, and structurally, one of the big push for the 50 states to have approved immunization came from the idea of having a terrorist event. That was one of the big pushes there, okay, If you see the graph on the years, it matches that. It was one of the big pushes. So I think we have to go down the list of topics. I think some of them we have already. We don't have the slides, those slides. So I think we have covered many of this. I don't know how we're doing with time and how much more time we have left. Okay. Okay. So we need to go through all these different areas, and maybe Elena can help us go through them with the cases. And one of the things that we needed to discuss is we can choose now which one of the two cases we want to look into to talk about the overall description and objectives, the strategic alignment, stakeholders, options, description. Okay. So we can do it for both cases, or we can pick which one of the cases would you like to go into more details into this area. The turkey case or the immunization case?
Should we do that for specific cases, or should we do that for professional associations being the stakeholders
We can do
right
it.
away?
We can also do it right away with the hour we have. We can decide to do it, because at some point we would like to go out beyond pharmacy and open it up to the other associations.
To
and how do
professional
they see that?
associations. Is there a preference in this group? Do you want to take one of the cases and break it down into stakeholders, et cetera, or should we just go into professional associations and what are the stakeholders there? And okay, do the second.
Mm-hmm.
Okay. All right. So I'll leave the microphone here, and I'll be the scribe.
And I'll ask questions, and you can you can help us with this. So we have many associations here represented. So any of you could volunteer to see what kind of project would you describe of the objective of a project that you think that you are already involved in, or your association, or that you think that will be a good description of a project that your association could take that could be of high value CPD. Any of you can think of something that your association is doing?
Professional associations. Are we taking a specific project, or are we just talking about what would it take for a professional association to deliver CPD? Who are the stakeholders? What are their stakes? So we can talk about it in terms of possibilities, and then maybe focus in on a specific project. Okay.
Maybe I can kick off and just give them some ideas.
There we go.
I think what was so helpful to me, particularly from Elena's discussion this morning, presentation, but also it aligned with many of the others. For me, there was just a growing awareness that when you're trying to look at the value proposition, as has been outlined in terms of quality outcomes over cost, that's going to vary from stakeholder to stakeholder. I mean, you can perhaps try and roll that into one value proposition, but I think the complexity of trying to roll it up into one value proposition is extremely difficult, and I think that's maybe what we try to do sometimes. But maybe it's a little bit more helpful, because as you recognize the multiple stakeholders in any of these initiatives, and you can probably list 10 or 12 key stakeholders in either of these examples and any other example that you can think of, but for each of those stakeholders, their value proposition is going to be somewhat different. And even as we had discussion this earlier about the patient perspective and preferences, sometimes even conflicting or, in competition. So I think if we look at a professional organization, we have to recognize what its mission is. How does it define value? So I think most of you are from professional organizations. And how do you define your mission? How do you define what is valuable for your organization? And how do you justify, for example, investing a lot of money in developing a very good program, whereas the benefit actually does not accrue back to you, it accrues to someone else or to society or to funders of healthcare. It does not accrue back to you, but you can see it as perhaps part of your mission. So how does that work for your different associations?
Again, Kathy McGuinn from the American Association of the Colleges of Nursing, and we're the national voice for baccalaureate and higher ed, and we have 810 schools. And so actually, advanced practice nursing falls under our rubric. And I would just say that an underlying theme that I'm hearing from some of these case studies was that we wanted to help our professions to practice to the full scope of their practice, and that's been a big issue for nursing. I think only in 16 states can nurse practitioners practice to their full scope of practice, and it's something that we're constantly struggling with. The 2010 Future of Nursing Report had that as one of its priorities, and we continue to work on that. And I think that's what I'm hearing pharmacy trying to do, and I bet a lot of the professions are trying to do.
Yes, again, I'm Karen Lacey, representing the Commission on Dietetic Registration. And we have, the Commission on Dietetic Registration has a number of specialty certifications that we are responsible for. And the most recent one that evolved over about, well, the last 3-4 years, and it follows your comment about being able to practice at a high level. We have a advanced practice in clinical dietetics that the first test was just administered, and we've just credentialed our first round of practitioners. And that came about through a fairly extensive study of trying to discern and disseminate or delineate what exactly an advanced practice in clinical nutrition was described as and what would be the stakeholders. And unfortunately, like a lot of trying to advance your scope of practice, and I heard you say that about the pharmacists, you're not necessarily paid a lot more for it initially just because you have this certification or credential. However, we're hoping as a result of it that it will increase value of the institutions by seeing that they now have clinical practitioners who are practicing at an advanced level. The other thing that we've done as a commission, we're really very proud of, is, and we're in the initial stages of developing a interdisciplinary credential for weight management. And we have worked very hard over the last 3 years in involving a lot of the other professionals who would be interested in obtaining this particular credential. So we're getting ready to do beta testing on the questions, and we'll be making it available over the next year or so. So those are some things that we're doing with the commission. And in listening to the process that was described this morning, and thinking back on how those new credentials were evolving, a lot of the things that were mentioned were what we were doing, looking at stakeholders, looking at what would be the cost benefit, et cetera. If we were to take something that isn't done yet in terms of a continuing professional development, because we can provide that, and then we also accredit other providers to give continuing education, is in many states, and I thought of this with the pharmacist, in many states, dietitians now have been given the authority to write diet orders, but that wouldn't have been necessarily part of their original training. And so that could be actually a model much like what you were talking about with the pharmacist. How do we develop a continuing professional development program that allows for quality assessment and ability to write diet orders that are designed effectively and safely for the patients?
So we can put that in terms of the challenges. Thank you.
This is back in my days on the APTA Association. We actually, it was 20 years ago, but we used high quality and value-based CPD instituted through a pilot, and it took its own, I'd say, its own wings, a train-the-trainer model to advance clinical instructor education. And there are now 2 tiers, with a third being developed, so a basic level, fundamental, and advanced, and now a third one. But we have, over the period of the time since it's been instituted, over 60,000 people have been credentialed as instructors. And the real reason why wasn't financial. It was to raise the level of clinical education for our students to be more in alignment with what was happening in the profession as we were advancing degree, as well as scope of practice and direct access, et cetera. So that program is really now owned by well over 200 trainers who really upgrade, take care of the program. It is managed by the professional association, but the real investment and ownership for the quality of that program and the ongoing assessment and the credential is really invested in our trainers who have been, they've taken a train-the-trainer course to teach the course using standardized curriculum with a very active, innovative training model. So it's actually taken hold in a very different design where it's not owned by the profession, the association, it's owned by the profession and its members.
I've been hearing something that for the associations in terms of the scope of the CPD and involvement in, it's a lot of the credentialing part of it, right? Because it's the credentialing tied to high value CPD that other providers of CPD might not have that power of credentialing as the association have. So that credentialing part, I think, is what makes unique in a way the role of associations, because it's more aligned to credentialing of the profession itself and the scope of practice that, for example, if CPD happens in the workplace, because this has another level of authority or understanding of the quality for the whole profession than if you do it in another venue. So I think that as I hear it more, I'm starting to understand the value of getting the association being involved in CPD, because they can tie it to credentialing and changing the scope of practice.
A naive question, are associations, professional associations, always the credentialing bodies?
No,
or they're two separate things? Okay,
no,
so I kept them separate. Okay.
Separate but they are more, they talk more that language and are closer to the credentialing part. They're closer partners, right?
An example of that, I'm sorry, did you? We have the Academy of Nutrition and Dietetics, which is the voluntary professional organization. And about 60% of our credentialed practitioners, of which there are over 100,000 right now of registered dietitians and technicians in the United States, are members of the Academy. And then there are 2 additional bodies. There's the accrediting body that accredits the undergraduate and supervised practice programs. And then there's the Commission on Dietetic Registration that oversees the registration eligibility. We have some specialty certifications above and beyond what I just mentioned. And then all of the different, we accredit other providers to provide continuing education. So we're the overseer of those accredited providers. And then we also are responsible for the process by which the credentialed providers develop their own learning plans. And we've instituted just now, and we're rolling it in over a 5-year period, a process that follows your model for continuing education for pharmacists, where we are basing our learning plan on practice competencies. So we've extended the concept of competencies beyond the entry level and eligibility, and now asking practitioners to come up with their own learning plan based upon competencies. And that's been validated, and it encompasses knowledge, behavior, attitudes, and skills. So that's, we're really excited about how that's all evolving to make practitioners more accountable, so that hopefully we can get to how do they apply it rather than just thinking about what they've learned.
I would let you know there is another independent organization that accredits professional development, IACET, and it has international accrediting competencies about what professional programs who offer CPD have to meet in order for them to award any kind of approval process. So one of them is IACET, there's others, but that means there's a higher body above the profession. So even if they're awarding it, I wanted to clarify, they don't have sole ability to do that without an organizational oversight that says you have to meet certain standards and criteria in order for you to have the recognition to award continuing education units or credits or whatever those are.
So where would you put this? Have we captured it through this, or are we missing a stakeholder?
I don't know if we have, there's independent agencies that are credentialing. So there's accrediting bodies.
Right.
And then there's a body that accredits just continuing education. So it's not program accreditation, it's continuing education. I don't know if you guys use IACET or another one, and it has a whole nother set of standards you have to uphold, that every course has to have certain things and elements demonstrated or it will not give you the license to award the continuing education.
So it's accreditation of continuing
Yeah.
education bodies.
So LCME, there's others, but it's an external body that then has oversight for what the professions want. So we don't get sort of, invested in our own that we're perpetuating.
But the getting drowned in the alphabet soup of all of these organizations have no meaning whatsoever until you get down to how does that impact the state laws that are going to empower the scope of practice ultimately. And so while I think every one of our professional organizations can list different models that are used to approach and to certify and to accredit, and most faculty have no idea what the difference between those two words is, but ultimately, what if you're to get to patients eventually, then we have to deal at some point with the individual state laws. And it's like Medicare, we don't have Medicare, we have 50 Medicares, and so we have 50 different laws on that too.
Absolutely.
Yeah, I just want to add professionals, because I think members, one of the stakeholders is like the institutions, the members, but professionals.
Okay. So let me just say, let's call these institutions. Okay. And then we could have the professionals.
The professional, yeah, because sometimes the institutions, they need some things or they think they believe some development things, but then the professionals themselves will also need something else.
And I'll just put the employers separate from the member institutions.
When I think about the American Dental Education Association, it's really the association for dental hygiene, dental schools, et cetera. So it's a very different community that's educating students and residents. So you could certainly include them as stakeholders under institution. But the charge for them really is developing the faculty and the leaders of the clinical education programs. And so I think the stakeholder would be institution, but we have to remember that some of the associations are involved in that component of health professional education as well.
So for us to decide whether we need a separate line for this, would their stakes be different? Would their costs and benefits and their involvement in this be different?
Well, if I think about dental education and what the American dental education does in terms of CPD, some of our challenges, for example, are recruitment and retention of faculty. How do you develop faculty? How do you give them the skill set to be good educators and assessors? Because many of us as clinicians are kind of thrown into teaching others, whether it's in a residency program or dental medical school, et cetera. So, it's slightly different, but certainly the association has an interest in recruitment, development, retention of faculty for that community of dental schools, dental hygiene schools, et cetera.
All right. Should I make another one down here, another stakeholder then? Educational institutions, maybe? Yeah. And these up here would be the non-educational institutions. Okay, members. Please.
Would you also, if we're talking about stakeholders, want to put in there the general public or / patient? Because the validation or the presentation of continuing education or a credential should mean something to the patients with whom we're interacting. And it should add value then to our services, regardless of the profession.
Absolutely. So patients would be up there for sure. Okay.
Might also want to look at legislative bodies. And is that up there?
Well, we have the federal state laws.
Sure. Okay.
That would probably capture this as being a stakeholder.
Mm-hmm.
So we have 10 stakeholders for this, which is not unusual, Is there anybody we're missing from this? None of the obvious?
How about the actual providers?
Providers?
Well, you've got providers who can provide CPD, providers of care themselves.
Would those be the employers?
No.
Professionals, that's the professionals.
The employees, well, yeah, the professionals that are providing all the different, it's under professionals?
So we have the
Okay.
people, right, the professionals,
Yeah.
and then we have their employers, and
Yeah.
then we have providers. Are we missing something, or you think we've captured it?
Elena, what about funders of healthcare?
Funders. Funders.
I think they're a big stakeholder.
Funders. Funding agencies. Insurance companies?
There's many different ways to fund healthcare, so that's going to be a big diverse group.
And that also depends on which association, because some associations, like, for example, in the pharmacy world, the pharmaceutical industry could be a direct or an indirect funder in many ways, even if it's being criticized a lot in terms of the tension of the value of education when the industry is involved. Again, it could be a big partner when we can, and new technology in a market-driven place, the new technology comes from the industry. So we cannot dismiss it completely as a partner, a stakeholder, knowing the risk of it. I think that, as you say, each stakeholder not only carries a cost or a value, but it also carries a risk of including it.
So should we include then industry? Broadly defined, and industry would be the pharmaceutical, the big pharma. Is that what we're talking about?
No, but I think that every one of
may
our
have a different
professions
industry.
have an industry behind it, especially if we talk about the dietitians.
That's right. That's right. 11, 12, 13. I'll put 13 number here, and I'll put industry. And you can look up there. It's much more nicely put. Okay. So number 13 is our industry. Yeah.
Well, I think you could turn an 8 on its side, and we would end up with a number of possible
an infinite
stakeholders, in terms of infinity. But if you say professional associations, as I understand a stakeholder, the other professional associations are stakeholders in any policy or continuing education or scope of practice that APTA is involved with, ASHA would be a stakeholder,
right.
Medicine would be a stakeholder, every other healthcare delivery system
absolutely
is somehow a stakeholder in the scope of practice of any one of us are, and we kind of dance around that some, but it truly ends up being the stifling entity when you get down to the state law sometimes.
Absolutely. And maybe we can deal with it right in here because we can expand this infinitely. But the bottom line is, which ones of these would be the main stakeholders? Because there could be a lot of stakeholders. And what's very important initially is to get as many stakeholders as possible down here so that we don't miss anybody from here. And then as we're going through each one of these, what are their costs, what are their benefits, what's their stake, what's their interest in doing this, right? We might decide that some of them are not as relevant to the particular initiative that we're focusing on. And if we look at another initiative, maybe some of these might become more relevant. That's a very, very good point. And I'll just put here professional association, and I'll just put main plus other related, right? So that we don't forget that that might be a consideration. Yeah. Do we have our main guys up here? Okay, we have 13 plus guys, right? So now, what we really have to do is to focus on what we think are the main stakeholders here. And I don't think we have the time to go through everybody, but if we can pick the maybe 3 or 4 main stakeholders that we think would be involved here, and we can go through their costs and benefits and why they would be interested in engaging in this, then we can finish that, and we can then, if we have time, move on exploring more of these. Does that sound like a plan? Okay. All right. So I'm taking votes. Who wants, I'll see a show of hands, guys. I'll call out the numbers, and the show of hands will tell us whether this should be included in the, let's say, just 4 stakeholders or not, right? Take a minute to figure out who your 4 are. And there's nothing magical about 4. It could be 5, right? So put down which ones you think they are, and then I'll just be calling the number, raise of hands, and Megan here will tell us who the winners are.
Just to clarify, number 2 is providers of education, because I think we have health professionals as number 6. So to distinguish between 2 and 6, I think we're talking about providers of education, CPD providers as number 2. Is that correct?
That is correct.
Right.
Is those that we train and they provide. Yeah, the association trains them or not trains them, right? But they're providers of CPD.
We use these numbers for Megan to be able to.
Yeah, let's use those numbers up there. Well, unless you took notes on this, in which case we'll use these, these over here. All right. So, professional association, the main professional association. How many of you vote with your hands that they should be included as stakeholders in this? All right. So I think it's a safe bet to say that these guys are in. Providers who can provide CPD. Okay. 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 Credentialing agencies. All right. That's a maybe. Member institutions. Accrediting agencies of continuing education bodies. All right. Federal, state legislature. All right. The professionals. Okay. Their employers. And educational institutions. All right. So, Megan, you probably got these, but I think we heard professional associations. I think we heard professionals. Oh, sorry. Oops, oops, oops. We have more. Funding agencies. Insurance companies. Industry. What did I skip?
The public.
Patience. Sorry, patience. I can't read my own writing. Patience. Okay. All right. So we have patience, I think. We have professional association. We have state laws, federal and state laws. And we have professionals.
She's got the score up there.
Oh, sorry. Okay. First one, too. Awesome.
5.
Okay. Do we want to put the employers of healthcare professionals? That got quite a few votes also. There's nothing magic about deciding, right? That got quite a few votes also. All right. Okay. So those are our the stakeholders that we are going to focus on in terms of costs and benefits and why they would be interested in doing this. Not to say that the rest are not important. They are. But these seem to be the ones that are the most important. Right. So Mike, do you want to run the one on costs and benefits?
Okay.
All right.
So I think when we looked at the examples, we've had several examples today, and we can define a problem or the issue, whatever the issue is, whether it's immunization or whether it's asthma or diabetes. We've had various examples. We can define the problem, but we know that in terms of how the stakeholders are going to see it, they're going to see the same problem from a different perspective. So they're going to define what they want to get out of it, the benefits that they might get out of it, the cost, the investment, what they put into it, is all going to be slightly different, and that's going to be very much related on what they get out of it or what their mission is, for example. In terms of costs, we know that there's going to be some costs that are relatively easy to measure. There's going to be a lot of other costs that we've heard about today which are not so easy to measure, not as direct or not as tangible. And again, in terms of benefits, some of the economic benefits we can measure, whether they're in terms of cost savings in terms of access, reduced usage of certain resources in the health system. All of those can be measured, but there's going to be other benefits which are going to be a lot more difficult to put a tangible cost or a measurable cost on. So I think recognizing the 6 major stakeholders, are we going to start first of all? Which was our top one? Was it the association? Was the association professional association? Again, if we use the example of immunization, we know that the American Pharmacists Association invested a lot of money to develop the course. That wasn't the only cost. There were other costs. There were costs to the pharmacists. You could probably look at opportunity cost for the pharmacist, direct cost for the pharmacist in terms of fees that they had to pay or the employer had to pay. The costs for the employer could also be quantified in terms of lost productivity while they were training their pharmacists. So I'm not sure exactly how we want to do it. Do we want to take one at a time?
One at a time, I think, and maybe talk about what might be some of the costs that are incurred.
Right.
What are some of the benefits that might accrue for each stakeholder? And of course, I think
these will vary based on the mode of delivery, right? If a professional association decides to partner with academic institutions, for example, and it's not the association that is bearing the costs of developing the courses, then the association will not have those costs. So we can have some costs that we identify, and then we could just put notes that, well, this will vary based on the delivery model that we choose. But it's important to capture those costs because someone is going to bear them, whether it's the professional association or whether it's going to be one of the providers that we have identified as additional stakeholders. Okay. All right? Okay.
So first of all, our professional association cost of, what costs is the professional association going to incur? Let's look at direct costs that the association would, and I think both of the case studies we presented this afternoon have been led by the association, and they incurred a lot of direct costs. Do we want to list some of those direct costs associated with the program? Yep.
Well, actually, there's a laundry list, so it's
Sure.
the cost of actually developing whatever the curricular content is.
Right.
And whether that's shared or not, and how to do that. The cost of the actual mode of delivery. So if it's on site, where are we hosting it? Who's coming up with the technology, the LCD, all the cost of all the AVs, those types of things.
So delivery costs.
Right, so online. And then who's doing the teaching? So whoever the individual or individuals are who are providing the training, there's cost. And then depending on the mode, you also have costs that could be associated with food and beverage, if it's on site or not. They pay their own. All those are certainly negotiable types of costs. Space, if you're doing the university for free. I mean, there's all kinds of ways to mitigate minimizing those costs or eliminating them.
Yep.
There's also the cost of promotion.
Promotion, marketing. Yep.
Well, certainly if it involves a change in scope of practice, and we talked about the legislative part, so the association often does a great deal of advocacy.
Good.
At the federal or state level as applicable.
Another one over here.
Yeah, I think not just the marketing, but the actual recruitment of the individuals and the selection process for classes, the faculty, finding the faculty, recruiting the faculty, maybe train the trainer.
Sure.
Was mentioned. And I think also documenting and publishing, because otherwise we don't share the knowledge, which I think is important for the learning environment for our professionals.
So materials, guidelines, all of those kind of things. We spoke about a little bit, partnering. So there's the cost of expertise. I think this week maybe haven't quite captured it. You likely to have to pay for expertise to develop your training materials.
I would think with the association, some of these are beginning to sound like they're also the cost of the actual provider. And I don't know whether we've assumed that in this case the professional association is the provider or not. If they would be, then that would be applicable. If not, then some of these are more attuned to the actual provider. But I would think even before much of the program development would occur, you'd want to do actually a needs assessment, and that could be somewhat costly and time-consuming.
Yeah.
And also the actual registration, you want to keep record of who had taken the because you have to have a infrastructure for documenting the actual course taking, right?
Yeah. So needs assessment and probably research related to that. Other aspects. What are the laws? What are the regulations? What's the CDC guidelines, etc. In some of the examples. So
Yeah.
record keeping. Yep.
And I think also it's often the association that will develop either, when we talk about the business case for it, to review that evidence and make the case. So maybe it's bringing experts together to develop a white paper or a position statement that makes the case for why this change needs to occur.
Maybe we can just capture that under needs assessment and research. I think sort of needs, that's perhaps related topic.
There may
Could
be
be focus
additional
groups, whatever, yeah.
There could be additional costs for, depending on who the provider is, who's paying for the CEs. In terms of the CE units, there are costs to the whoever the provider is to assume costs for awarding CEs. And the other part is, depending on the nature of the assessment and the rigor, it may have to undergo testing for whatever it is you're assessing. If it's a high stakes threshold, then there has to be some assessment testing before you actually deliver that. And that's expensive.
Right.
Another point could be a way to defray the costs is to seek grants. I know AACN, we did a huge quality and safety education for nursing program over a 5-year period, and we received $3.5 million from Robert Wood Johnson Foundation to just cover these exact costs that you've just mentioned. So that's always something I think associations are looking for is grant funding.
So should we put the grant funding as a cost, meaning that there's a cost involved in developing a grant proposal, right?
There is, yeah.
And then if we get it, that's wonderful. It becomes in money in cost of developing grant proposals.
Maybe just to capture, Megan, under the cost of assessment, maybe we just put also accreditation. I think you were talking about maybe there's going to be a cost for accreditation of your course, and even awarding the credit can come under that general cost as well. Probably it's got the main ones. Do we want to look at costs for the other stakeholders, or do we want to look at the benefits now? Otherwise, we're probably not going to get through them.
What do you guys think? As we're thinking about this, professional associations go to the benefits. Okay?
Okay.
Do that.
You're finishing at 4:30 here, right, Megan?
Mm-hmm.
Or 45.
Okay. Because at some point, I think we should go to the benefits, because at some point we have to make a statement of is it valuable or not for associations to invest. We should leave the 15
Okay.
minutes for that.
So professional association benefits.
Well, my first thought was to always start with the people we serve and say that ultimately patients care and better, the triple aim plus one.
Okay.
That hopefully anything we do in healthcare ought to be moving toward that. Now, I don't know, I guess you could argue that that's not benefiting the association directly, but I think it is. I think that's what our association should
Well,
be about.
it's meeting their mission, isn't it? So it's a benefit.
Right.
It's achieving the mission, which is ultimately to improve its membership, but also the end point is in most healthcare professional organizations is improve care for the patients. Okay.
So
Mission
I
of
put
the
improve
organization.
access. That might be one, right? Increase quality of care, reduce cost of care. That sort of capture it.
And like you said, increase membership, because if the association is seen as a valuable originator of continuing professional development, then that's an incentive to join, because usually there's a differentiation of cost for programs if you're a member versus a non-member. So that could increase ultimately revenue for the association.
Could also help schools in recruiting students in terms of saying, you know, it's a profession where you've got a broader kind of scope of practice. And also in terms of partnering with some of the, this is a separate one, partnering with some of the commercial.
So this would be better recruitment.
For the profession.
I think just collectively, some of the comments I've just heard is advancing the profession and the public image of the profession.
Yeah,
I think are two things. Public image is going to attract more students into the profession.
And if you're going to partner with companies or corporations, certainly you're raising their profile in terms of them being able to bring patients in.
So that we would wait for that and just say that this is a benefit to
Yeah.
not the association, but
Right.
to the providers, right? Mhm.
Reading back to number one, as a health, public health professional, I have to say that we need to go beyond, at least we do, we go beyond patients. We talk about maybe the health of the population or, to improve, the health of the population.
So just say improve population health?
Yeah. I think another one is, I think I would call it alignment, but when your new group of students are getting new skills and knowledge that your practitioners don't have, there has to be a way for profession to do better alignment, that those in practice are not left behind as skills and technology change. So there has to be ways that somebody undertakes the responsibility of making sure that there's not tiered practice, that everybody's in alignment.
Is that a benefit to the association, or is that a benefit to the individuals?
It's mixed, because if the association puts it on, oftentimes it also is a backdoor for some other things. And if they don't provide it, then you hear your people, you may lose members. So it may help membership, but it also helps how the public views the profession. If you have some practitioners who have and some practitioners who don't, it will affect almost everything about how you do that. So part of it is an alignment. And a perfect example is when a profession elevates the DPT and the next generation, or that had the doctorate, the profession, and the other generation does not. If you don't do something for the people practicing, they're angry that they were born in the wrong time, essentially, and don't have that degree.
Okay. So I'm trying to think about, help me capture this benefit in a benefit way, right? Because I think what I hear you saying is that it will influence, misalignment will influence the image of the profession. It will also decrease membership because you will have disenfranchised members. But you're capturing something else, which is a causal mechanism behind all of this. How should we capture it here as a benefit?
Yeah, I think it moves to almost an obligation. It's an obligation that the profession has to take care of the larger interest of those in the profession. And so it's not just to garner members. It is.
So shall we say fulfills obligation? Fulfills obligation.
It fulfills the obligation of the profession, that the people practicing are practicing at best practice and using evidence-based practice levels. So an example is, before evidence-based practice existed, a whole new crop of health professionals were educated in evidence-based practice, and a whole group of practitioners never had that background. There has to be an obligation to bring everybody to the same place who's not currently enrolled in those programs.
Do we want to move on to a second
second
stakeholder? I think we've maybe got enough on this one. Otherwise, we'll run out of time.
Any other benefits that we need to capture here? Boy, if these guys are funding this, these are slim pickings. From a financial standpoint, right?
I mean, a lot of associations derive money from conferences. I mean, and publications. So it's going to be a revenue model to get more people to their conferences and more people to subscribe to their journals. So that's a tangible.
Well, there you go. Is that something that, or does that go under increased membership with all the benefits that derive from that, or increased?
Well, it's revenue, increased revenue opportunities.
Revenue opportunities.
It's not dues revenue.
Increase revenue opportunities for conferences, journals, etc.
So, with that, even though we're going to talk about, I think, the secondary stakeholders, but certainly the opportunities for companies that manufacture the drugs or the vaccines, et cetera. They can co-sponsor these events, and there's a certain amount of money that the association can get from that relationship.
So encourages company sponsorships with the revenue. And then there's revenue from whatever tuition is, right? From whatever they're charging, right? If they're charging. I'll call it tuition. Okay. Someone said scholarships. I heard someone say scholarships here. Okay. So what was the scholarship want to capture?
Depending on the type of data that is gathered from the evaluation process, you could be able to advance scholarship for the association.
Okay. So fund scholarships, possibility?
Oh, no, I think you already captured it in your notes.
Oh, okay. Oh, okay. Okay. Right.
We spoke also about goodwill earlier, and I guess the reputation. I mean, reputation as an organization is something maybe we haven't quite captured here, because that's very important for an organization, particularly in the professions, to have a good reputation, a good credibility as an organization that's committed to learning and innovation and advancing. It's not stagnant. So I think that's a tangible benefit.
All right. Next stakeholder. Who was our next one that did really well? Your choice, guys. Health professionals, providers.
Professionals.
Health professionals, all right. Let's talk about their costs first. Time. Does the travel go into time, tuition, or do we have it the cost of transportation, tuition plus incidentals?
I would think opportunity costs too, because they're going to many times be away from work. Not only is there tuition for the program, but to maintain your credential, there might be an annual fee that is paid to the credentialing body.
Probably have to pay that anyway.
Are there any fees for credentialing exams that are outside tuition, or is that covered by tuition?
There is an application fee after that, and you have to keep taking CEs. Once you get into an area, you have to keep it up, right? In some states they do, and some states they don't. It's a separate thing.
So we'll have the tuition and all of that for the various courses, and then we'll have the annual fee to the credentialing body, and then the fees for credentialing. And by loss of autonomy, you mean in the way you practice?
No, I think I've heard a lot of healthcare providers get frustrated at having to attend a lot of CPD for regulatory or compliance reasons.
Okay.
Kind of a frustration with the process. You know, every year having to attend things for regulatory or compliance issues.
I just put it cryptically here, but it's frustration with having to take these continuously for compliance, to stay in compliance, right? Are there any other costs for these folks? Shall we put benefits down here? And how appropriate? Benefits are in green.
Stay current with and best practices.
Stay current with best practices. Anything else?
Network.
Expand their network.
It's also that they can have choices in terms of how to practice. They have more choices of things to do.
Increased professional opportunities.
Okay, opportunities, yes.
The possibility of a centralized data repository for research purposes to demonstrate outcomes.
Is this a benefit to the healthcare professional? Or is that a benefit to the profession, to these folks over here, right? Oh, all right. So a couple of more benefits to round this off, and then we'll stop.
Protection, because they can continue to practice safely as things evolve. Safety, as they can, continue to practice safely as healthcare evolves.
Okay.
Increased income.
Increased income.
Possibly job advancement as well.
Mm-hmm. Job advancement.
Keep up with credentials, because in some organizations they ask you to be updated and.
Yes.
We have 2 minutes before we reconvene with the whole group, and we have to make a statement as a group. Like, do you think that there is a place for high-value continuing education for associations? We need to have a statement like that. Does this convince you, or what was your thought about that big question? About what do you think association should continue investing in this? Is there a role for investing in it? We need a statement or
I would say yes, but it depends on what the issue is, perhaps. And I would like to ask a quick question about the risk assessment. I remember optometry in the state of Oklahoma in the 80s when they pushed to be the first to prescribe drugs through optometry. And I remember the radio ad was the medical association. I was an undergrad then, and you could hear this beating heart, if you will. And then by the end of the commercial, the heart flatlined, right? And the risk is that if the optometrist in the state didn't win, and my school had an optometry program, so if it didn't win, was the message to the public, optometrists will kill you. So how do you, in the risk analysis piece, which I know we don't have time to get to, but where do you factor that in, and how do you determine the weight that carries in your ultimate decision to go or no go?
Any other overarching comment? Because we have our other friends coming in the room. Okay, so I think we can wrap it up. Okay, and
What did we decide? Should they do it or not?
we decided that they should do it, right? But think about those specific risks that some change of scope can bring.
I think the risk that you're talking about for procedures, let's say, new procedures, in medicine, you're taught to see one, do one, what is it? See one, do one, and then teach one. But it's all about the practice and with experience. You know, we need to develop more experienced health professionals. So at whatever level, whatever allied health professional, if you give them new tools and new skills, they're going to need to practice. So that's how you get rid of that risk. You counter that argument.
So you're saying that
That's why we have
for
residency programs or internships or some type of teaching and training attached to the new skill development.
So you're saying that we can take your comment and say that the professional associations should invest in that kind of training that will give more experience and practice, especially when something new comes up. The more practical what you say about the opportunities to apply. Simon?
So when we look at these kind of issues in medical sociology, we think about CPD in the context of the last 100 years of health professions. So when you say about should professional associations invest in CPD, that's not so much the question for me, it's for what reason and how they do it. So for medicine, it would be about maintenance of clinical autonomy. We tend to look at health professions in terms of the amount of clinical autonomy they have and how that facilitates their clinical practice in the workplace, the relationship with other professions, relationships with the hospitals, health insurers, et cetera, et cetera. So for some health professionals, it's going to be about maintenance of clinical autonomy and clinical territory. For others, it's going to be about the birth of expansion of their clinical territory and how they then deal with new relationships with health insurers, hospitals, other professionals, patients, and so on. So I think that this is one question where, or if it, as a value proposition about being involved in CPD, I think interest-based, each health profession would have an interest in doing CPD. It's about how you outline it and get them to think about the big picture in terms of the growth and advancement of their profession, and then down to the minutiae of how that organises their practice in relationship to patients, other health professionals, the workplace context, hospitals, institutions, and economic issues, and so on. So for me, there's no why in that question. It's for what reason and how they engage in CPD would be the way that a medical sociologist would look at this kind of issue.
Thinking in competencies, I think that the needed competencies are keeping on just changing and changing, and the needs of the population and the risks are new every day, so you really need to keep on doing CPD, otherwise you're not going to be approaching the health of the population, and the risk is that we're going to lose the battle of the health.
Simon, I think it's just summing up what you said is really continuing to add value in a constantly evolving world. Technology, disease patterns, morbidity, all of those kind of things. It's continuing to demonstrate value, because if you can't, someone else is going to eat your cake, you know. I mean, that's what...
Absolutely. Yeah. And that's the thing. So we talk about lifelong learning of the individual healthcare professional. We've got to think about lifelong learning for the professional association. And not as just a value proposition as it's the right thing to do, but tactically it's absolutely essential for relevance and for impact in healthcare.
Yeah.
And also, in wrapping up, I think that another thing that we should ask ourselves is no other entity can do it. Right. Because no other entity has as a mission the advancement of the profession And I think that you said very well, they might do other things like workplace, the universities, but the mission of advancing the profession is unique of this group. So I guess that should be something that we should include here.
I was going to add that if you don't do it, the consistency and standardization with what your profession can do it based on evidence and best practice, the void will get filled, but it'll be filled by unique small entities, each doing them in their own way. And so what you end up with is a Tower of Babel. You end up with a lot of different things about topics and no way to really understand where are we. And so I think the risk of not doing it is your profession is at stake if you don't have consistency and standardization about what you do.
You know, we kind of brought this up in the morning. When I go to my annual meeting of the American Academy of Periodontology, I mean, there's a lot of CPD that goes on with that organization, but there's also a lot of company exposure. And so the conflict of interest, I think, between those two entities and associations, relationships, obviously we need the companies. It's a great venue for exhibiting new technologies, new drugs, et cetera. But I think that's one caveat in there is to kind of, as professional associations and the ethic that we have, that relationship is always something that we need to keep in the back of our minds.
Okay, I think we can wrap it up and allow other people to come in. Thank you very much. I think good work.